Okay, so we are live. We'll wait a few more seconds to give people time to click in.
Make sure we can't see anything.
No, you're good. You're good.
Yeah, and just let me know if I'm quiet.
No, your volume's much better now. I'm going to wait 30 seconds and then we'll start, or about 10 more seconds and we'll start.
I told Brandy she should tune in.
Okay. Okay, we're going to start. I am Dr. Shannon Clark with Babies After 35, and I am so happy to be joined by Dr. Shannon Hardy, another Shannon. She is of Bella ObGyn in the Houston area. Can you tell us where your offices are?
We have 3 offices. We have one in the medical center and on the Women's Hospital of Texas campus. We have one that is in the Memorial Tanglewood area, and then we have another one in Pearland, actually. So
Perfect. So if you go online to Bella ObGyn and it's scrolling across the bottom on the ticker, you can set up an appointment at whichever location is more convenient for you if you're in the Houston area. Also, of a more personal note, I trained Dr. Hardy.
Yes, she did.
I finished my fellowship in 2007. She finished her residency, ObGyn residency, in 2008. So I've known you for quite a while. So I guess I know you finished in 2011. So yeah. I've known you since 2007. Yeah, it's been a long time. And so she went on. Dr. Hardy went on to do private practice in ObGyn. I went on to become maternal fetal medicine at an academic center. So I thought it'd be great to talk about preeclampsia, since it is Preeclampsia Awareness Month. And it is one of the most common medical conditions in pregnancy. And to have a viewpoint of myself, who is a high-risk obstetrician, so I see some really sick patients. Dr. Hardy as well has patients who are preeclamptic. And we'll start off just a little bit talking about the role of the ObGyn with the maternal fetal medicine specialist. You know, if you have a patient in your practice that becomes preeclamptic, how do you typically manage them? When do you consult MFM, or do you, or how does it typically play out?
So when we have patients that we formally diagnose with preeclampsia, a lot of times we put them in the hospital. If it's, whether they're severely preeclamptic or, kind of mildly preeclamptic, we definitely put them in the hospital to observe them, to do testing, monitoring of the baby. And we kind of watch them for a while, and we see if they're stable or if things are kind of escalating. We do consult maternal fetal medicine specialists, especially if they're very preterm patients, meaning less than 37 weeks, especially less than 34 weeks of gestation, to do ultrasounds on the baby to make sure the baby's growing okay, to give us recommendations if we need to do any blood pressure control, just to kind of co-manage and make sure we're giving the patient the highest level of care.
Right. So just for those of you listening, there's multiple ways that if you develop preeclampsia, and we'll go more into what it is, but just right off the bat, if you have it, either your general ObGyn will manage you. Typically, that's going to be if you're term, 37 plus weeks. If you're below that, and especially as Dr. Hardy said, less than 34 weeks, then they may consult maternal fetal medicine to what we call co-manage, meaning they get recommendations from someone like myself on, do we need to do anything else, recommendations on treatment or delivery when the delivery of the baby is indicated. And then sometimes, depending on how severe the preeclampsia is, they may transfer care to maternal fetal medicine. So that's all dependent upon the comfort level of the ObGyn, how early you are, what your gestational age is, and what's typically done at your institution, because every hospital system is a little bit different. So that's always a good thing to ask your general ObGyn too, if you start to develop any medical condition actually in your pregnancy. Would you agree?
Yes, absolutely.
Yeah. All right, so let's jump into what is preeclampsia. So I'm going to quiz you, Dr. Hardy, since you were my, what is preeclampsia?
Preeclampsia is a disease of pregnancy that is sort of, you have high blood pressure is the first criteria. And then also other signs of damage to other organ systems, like you have protein in your urine, which might signify that you're having some damage to your kidneys, or we do some special labs to look at your liver function. We make sure you don't have any symptoms of having, issues with swelling in your brain, like headaches and spots in your vision and things like that. So typically it's blood pressure plus one of those other things signifying end organ effects.
Right. And as you said, it only occurs in pregnancy. So preeclampsia used to be called toxemia. preeclampsia and toxemia, but now we call it preeclampsia with or without severe features. And that is based on how severe your disease is. The way I kind of explain it when I'm teaching medical students or talking to my patients is that the preeclampsia namely starts with elevated blood pressure. But why is that? Because it attacks the small vessels in your body. Where do we have small vessels in our body? Brain, kidneys, lungs, liver, placenta. And if you have what we call neurological issues, whether it be vision changes or headache, that goes along with the brain. If you're having elevated liver enzymes or liver function tests, as the doctors might call it, that means your liver is affected. If you have baby's growth restricted or having issues getting blood to the baby, that means the placenta is affected. So anywhere where you might have small vessels in your body is kind of where preeclampsia targets. And then finally, the kidneys. We always think about kidneys first because one of the first things you see is protein in your urine. And that means that your kidneys is just spilling more protein than it should. Every woman pregnant woman has some protein in her urine, but when you get preeclamptic, it becomes elevated. So yeah, namely you hear protein plus elevated blood pressures, but we also, what's atypical preeclampsia? I'm sure you've had those patients that we say, walk like a duck, talk like a duck, it's a duck. But then sometimes it doesn't necessarily walk like a duck, but it's a duck, meaning that it's preeclampsia, but it doesn't fit textbook.
Right.
So what do we do with those patients?
So if a patient comes in and maybe they have, severe headache, they're seeing spots in their vision, maybe they have a little protein in their urine, but their blood pressure is normal. Mm-hmm. That may be one scenario where we're very suspicious that's atypical form of preeclampsia. We typically do consult maternal fetal medicine in that case because it is not your bread and butter case. And we just want to get a second set of eyes and expertise that can really help guide us for treatment. We do treat atypical preeclampsia, like you have a kind of a severe form of preeclampsia. Mm-hmm. We keep you in the hospital, we monitor you closely. We sometimes have to put you on a medication called magnesium sulfate, which can help prevent seizures, which is one of the scary complications that can happen with a severe preeclampsia. It's just, we treat it like severe preeclampsia. We may have to deliver you early, usually around 34 weeks, if we can get you that far. But we always, watch you very closely with an MFM on board as well.
Right. So yeah, there is something called atypical preeclampsia that doesn't necessarily meet the textbook definition, but when you're starting to develop the signs and symptoms that really to us as physicians really looks like preeclampsia, we have to err on the side of caution and make sure that we're being, vigilant and doing what we need to do, because a lot of times over time, it will turn itself into preeclampsia. So basically, who is at risk for developing preeclampsia? Everybody wants to know, am I at risk? What kind, in your patient population, what typically do you see as far as risk factors go?
So the risk factors that are sort of the ones we keep on the forefront of our mind when we have a patient come in with pre-existing high blood pressure. So maybe they're just, a very healthy person, but have high blood pressure and they're on blood pressure medications. Maybe they're well-controlled off medications. If you have some type of autoimmune disease, like lupus or rheumatoid arthritis, you might have an increased risk of having preeclampsia as well. If you are pregnant with more than one baby, so if you have twins or triplets in there, you do have an increased risk of having preeclampsia as well. Diabetes is one where we watch out closely for it too. And then there's some kind of risk factors that are a little bit less, maybe you're in a moderate risk. It's your first baby, you're very young, or you're a little, maybe you're older than 35.
What we call extremes of age. Younger patients, the older patients, extremes of age, and also first-time pregnancy. If you're a teen or early 20s, first pregnancy, you're definitely at increased risk for having preeclampsia. So yeah. When you talk about diabetes and autoimmune diseases as well, it goes along with what I was saying about, the small vessels of the body being affected. Same thing with diabetes. Diabetes affects the small vessels of the body, namely the kidneys. So if you have diabetes and you become pregnant, then you're at increased risk for having preeclampsia. And also the same thing with something like lupus, because the lupus affects the small vessels of the body too. So that would also put you at increased risk for developing preeclampsia. Yeah. So, and then we talked about, there was a few other things. A higher
in the past.
What was that? Preeclampsia in a prior pregnancy is a huge thing. And we'll talk more about that as we go along. But definitely If anybody comes to me having had preeclampsia in a prior pregnancy, especially early onset preeclampsia, which is less than 34 weeks, I'm going to watch them because it's definitely one of the biggest risk factors for having it in the next pregnancy. We also have to talk about weight too. Being of a higher weight or body mass index greater than BMI greater than 30 is a risk factor. And also being African American is definitely a risk factor as well. So we have to keep all those risk factors in mind when we see any of our patients. Actually, I forgot to put that. So what is preeclampsia? We already talked about who is at risk for developing preeclampsia. We're going to go down to, so during your routine prenatal visits, we're going to talk about, everybody knows what happens then when they go to their prenatal visit, as far as everybody's got to give a urine, everybody's got to get their weight, everybody's got to get their blood pressure. But now we kind of know why. So what are those, why are we doing those things, Dr. Hardy?
So at every prenatal visit, you're going to leave a urine sample, we're going to take your blood pressure, and we're going to take your weight. Because, even though we may not be talking to you about it at every visit, we're always on the lookout for signs of those, other organ systems being, maybe they're starting to get a little bit affected. Maybe we should be watching you more closely. We're looking for protein in your urine. Every urine sample you leave, we make sure there's no protein. We're looking for sudden increases in weight that maybe is not following your normal weight curve. Are you having a lot of increased swelling that's making you gain weight? And then of course we're checking blood pressure to make sure you're kind of staying in the normal range and you're not suddenly maybe quite a bit higher than your normal low range. That just might tip us off that we need to start monitoring blood pressures at home, or send you in for monitoring at the hospital.
Yeah. So one of the things that for the weight and every woman gets some swelling, especially towards the end of the pregnancy, just because of the pregnancy, it's normal. And then again, after you deliver, you get a lot of swelling. But there's been times where a patient in between visits, especially in the third trimester, may have gained 5 to 10 pounds in 1 week. And then I'm like, uh-oh, what's going on here? Is it, reweigh, make sure, of course, it's accurate. But that is one of the signs, because with preeclampsia, you start retaining water. So it's called third spacing. The volume and the fluids within your vessels start to go out into your tissue, and it makes you swell. So if I have a patient who has what we call sudden increase in weight or sudden increase in swelling, then we definitely need to assess her for having preeclampsia. Okay. Now we'll talk about, when does preeclampsia typically occur?
So preeclampsia typically occurs after 20 weeks of gestation. If you're having high blood pressure before 20 weeks, most of the time we're going to attribute it to either you have a pre-existing blood pressure condition, and we'll need to do some assessments about that. Or maybe you have white coat hypertension, which is where your blood pressures may be completely normal outside of the doctor's office, but every time you come into the doctor,
it goes.
Blood pressure gets high. I always have a couple patients with that, but typically it's going to occur after 20 weeks of gestation.
Right. So, patients always get a little surprised when they've come in their first trimester or right after the first trimester, and they're starting to have blood pressures 140s over 80s, 90s, or 130s over 80s, 90s. And I'm like, and they end up getting a diagnosis of chronic hypertension. Chronic hypertension means you had high blood pressure before pregnancy. Now, you may not have ever been told that, but if you're starting to have high blood pressure in the first trimester, that's definitely an indication that you probably came into the pregnancy with a blood pressure disorder. It doesn't necessarily mean you needed to be on medication, but it's important for us to know. That's why also, while we're at it, why having early onset of prenatal care is important, because we're looking at trends. We're looking at little red flags that may not have otherwise been picked up. And the earlier we can pick up on those, the better. So yeah, I know leaving a urine is a pain in the what sometimes, and the patients are like, I can't pee. But we really need it, because we're looking for other things that we don't want to necessarily worry you about, but it's our job to check. The other thing I wanted to talk about is the early onset preeclampsia. And this is where we're going to talk about your story here a little bit. Early onset preeclampsia occurs at less than 34 weeks. Okay. So that is very important to know in a patient's history as well, when her preeclampsia occurred. Dr. Hardy has her own personal history of having early onset preeclampsia. Would you like to share a little bit?
Absolutely. So when this was almost 10 years ago, when I was pregnant with my first baby, and I was a resident with Dr. Clark as an attending. fourth year resident, and I was 31 weeks pregnant at the time and was working and was about to go finish rounding and started bleeding, which that should not happen at 31 weeks of gestation. So it kind of tipped us off that something was wrong. And then I, immediately got admitted essentially, and suddenly started seeing all these things happen very quickly. My blood pressure was going up. I was getting headache. I was getting chest pain and abdominal pain. I had protein in my urine, and the lab showed significantly elevated liver function tests, which is not good. That means there's some damage going on inside the liver. And when you start, I also had low platelets. So that's another thing we look at is your blood counts, and we see if your platelets are normal, because sometimes that can be a sign, if they're low, that something's brewing. Yeah. Right. So once we discovered all that and we saw that those levels were no longer stable, they started to increase rapidly. We had given my baby steroids. It's an injection you get, and to mature the baby's lungs. So within 24 hours, I got 2 doses of steroids, and things were getting worse very rapidly. And so we had to deliver my baby by emergency C-section at 31 weeks. And they had diagnosed me with a very rare, severe form of preeclampsia called HELP syndrome. So it was
and then you were so good at it the first time, you had to have it again. you had preeclampsia do you have preeclampsia with your second baby too, right?
No, I had
you had the other issue with your so she had preeclampsia.
Something we're going to talk about later.
What's that?
Because I prevented it happening a second time.
Right. Okay. Yeah. We'll talk about the second pregnancy later in the discussion. But yeah, so, with Dr. Hardy, her disease appeared very quickly, and we didn't have a lot of time with her, and she had to be delivered. Now, that doesn't mean that's the same way for everybody. Some women get diagnosed, and we can keep them pregnant for days to weeks, depending on how early it develops. So the key is catching it. But in some women, such as Dr. Hardy, you can't. It just comes out of nowhere, and it happens. So preeclampsia is a little tough sometimes to predict. And but just because you get it at 28 weeks doesn't mean you're going to have to deliver at 28 weeks. Hopefully, if everything else is stable, your doctor can keep you pregnant for a longer period of time, but with close observation. And then in certain situations, it happens so quickly that, and the patient gets so sick, as in Dr. Hardy's case, that we have to deliver them early. And how did your baby boy do? I'm sure he's doing just fine.
Oh, he's fantastic. I got very excellent care at University Medical Branch by my amazing doctors and nurses. And so I did great after being on a medication called magnesium sulfate that I talked about before. And then my baby Patrick was in the NICU there with awesome doctors and nurses for 6 weeks. And then he got to come home, and he has just, you would never tell he was born 9 weeks early.
Yeah. Yeah. Good. Okay. We'll go on to the next. Okay. What signs and symptoms? So this is for the person watching this who is not a physician. What are some of the signs and symptoms of preeclampsia that they should be aware of?
So things to kind of be on the lookout for, especially in the third trimester, because typically preeclampsia will occur in the third trimester, the most common time. If you're having severe headaches that are not being relieved by Tylenol, if you're starting to notice some vision changes, maybe spots in your vision or seeing stars, you can have that in pregnancy anyway, but still it's a sign you should pay attention to. If you're getting severe, maybe some belly pain or pain in your right upper area here, right under your ribs, that is associated with, the headaches and maybe some spots in your vision. If you're getting all of a sudden massive amounts of swelling, maybe in your face or in your hands, those are things to look out for. And the thing about preeclampsia is sometimes you don't notice anything at all. Like I felt fine. Until I didn't. And that's why it's really important to go to your prenatal visits.
Yes.
We're going to be looking out for those things. If you're not, because you can be feeling fine and arrive at the visit, and your blood pressure might be 170 over 110. But that's why it sometimes is very silent until you really start to have those effects on your other organs. So it's
really important. And the swelling of the face and hands, you might notice that your rings all of a sudden they're getting very tight or you can't get them off. Or maybe your significant other says, your face is really puffy today. Because it's hard for us to notice those physical changes of our bodies. But, I've had a lot of patients who it got picked up because whoever they lived with said their face was all of a sudden, very swollen. The headache that doesn't go away with Tylenol is very important. That's what I always tell them. If you take 1 or 2 doses of Tylenol and it's not going away, then you need to let your doctor know, especially if you're in the 3rd trimester or even after 20 weeks. The other thing we need to talk about is nausea and vomiting, and that's after 20 weeks. If you're just, and it's not nausea and vomiting that you have in the 1st trimester that a lot of women have. This is after that's already passed and you're otherwise fine. And then out of the blue, you just kind of have nausea and vomiting for really no good reason. You need to let someone know. And then lastly, if you have been otherwise okay in your pregnancy, but you notice that you're having shortness of breath or chest heaviness or, difficulty breathing, that's important to let your doctor know about no matter what. It could be a lot of other things other than preeclampsia, but in preeclampsia, sometimes you can get some fluid on your lungs. Like I mentioned before, when you start swelling because the fluid is going out into your tissues, the same thing can happen in your lungs. So it's not as common, but there's been several cases over my 20 years where it was picked up because they were having difficulty breathing and they ended up having some fluid on their lungs and it was preeclampsia. So, you know yourself better than anyone. And if you know something just doesn't feel right or is just something's not right, or you just don't feel right, it's always better to let your doctor know so that they can take a look at you.
Yeah, absolutely.
And, while we're on the topic too, the whole thing with COVID-19 going on and patients not having the same type of prenatal care as they did before that, because we've tried to minimize exposure by bringing patients in for good reason, obviously. It's even more important, we're expecting, I'm sure your office is too, we're expecting more calls because they're not having the typical prenatal care. So what would be your recommendation, if there's not a prenatal visit scheduled, just call and tell them, and then typically then your nurse will relay it to the doctor? How does it work in your office?
We are pretty good about email communication as well. So we do some email, and we do have the patients just call in. I always tell my patients, if you are pregnant and you're having an issue, it's always an emergency. So hit that.
Mm-hmm.
It'll give you a little prompt and you can hit that. It'll take you to somebody to talk to. And if the nurse can answer the question, that's great. She can answer the question, but if not, it does get relayed to one of the physicians that's in the office, so we can make sure we answer things in a timely fashion.
Yeah. And I also think, since you mentioned it, the whole, what we call My Chart, every hospital system has some kind of My Chart where you can sign up to where you can communicate online. Take advantage of that, because, it's actually a really good way to sometimes it's quicker than even if you call the office. So if your hospital system where you're delivering, or your practice where you're, getting your prenatal care has that option, my recommendation would be sign up for it. Would you agree?
Yes, absolutely. We have a portal system with our electronic medical record system. Yeah. So people just contact us through the portal. We have several ways: email, portal, and phone call. And, we don't mind getting questions. That is what we're here for. We're here to protect you and to protect your baby. Mm-hmm. And we know pregnancy is a really, unique time for your body and for different things that are happening. So don't ever feel bad about reaching out with questions. And that's what we're here for.
Yeah. And don't ever feel that, trust me, we get questions all the time, and it's what we're used to, especially we know it's you and your baby. And, especially right now when women are so stressed and they're worried, we are mindful of that, and we know and expect that we're going to get more calls and more requests, and that's perfectly acceptable.
Exactly.
We already talked about this a little bit, but how is preeclampsia diagnosed? So you have a patient come in because her clinic blood pressure was 140/95. What are the first things that we do?
So if my patient comes in, she has 140/95 blood pressure, I recheck it. Mm-hmm. Before we, jump to conclusions. I check to see if her urine had any protein in it. And, if her blood pressure remains elevated, I will send her to the hospital to get what we call serial blood pressure monitoring. So you go to the sort of emergency unit at the hospital. That's for pregnant moms. And we kind of put you in a room. We're going to monitor your blood pressure for an hour, definitely at least an hour or two. We put your baby on the monitor to make sure baby looks okay. And we order a bunch of labs, those labs we talked about that are going to tell us if there's any signs that other organ systems are being affected with this high blood pressure. We want to try and really differentiate, is this actually the disease? Is this preeclampsia? Or is it, we just had a couple elevated blood pressures. Maybe it's something else like gestational hypertension, which is where you have just high blood pressure and nothing else. And typically those pressures stay in the low range for, nothing severe, like 160 over 110. It's still something we would have to monitor very closely. If you are in this monitoring unit and the blood pressures stay high, or we see that in the labs, you have protein in your urine or any other laboratory signs that other organ systems are being affected, that's when we admit you for much closer monitoring.
Right.
If you're kind of checking out, maybe you have a couple elevated blood pressures, but everything else looks normal, we a lot of times will send you home and tell you to do blood pressure monitoring at home several times a day, keep a log, bring it to us, and we give you very strong precautions about those symptoms to look out for that we talked about.
Right. So, the way I kind of think about it, there's kind of three pieces of the pie of preeclampsia. And how those pieces are affected depends on how serious your disease is. You look at your lab values and your blood pressures. You look at what mom is experiencing, what her symptoms are. And we also look at how is baby being affected. And that you kind of have to put all those together to determine A, how severe the disease is, and B, when delivery should occur. Now, you may at that point, at day one, be perfectly fine to continue the pregnancy. But one of the reasons why preeclampsia is so important to really pay attention to is that from one day to the next, it could completely change. So, if someone is diagnosed with preeclampsia, I know, do you guys ever do outpatient management of preeclampsia?
Occasionally, if we have documented that you are very stable, the labs have stayed good, your blood pressures have stayed pretty low and stable, we sometimes will do very close outpatient management where you're coming to the office probably 2 times a week to get, blood pressure checks, monitoring. But a lot of times you wind up just having to stay in the hospital until it's safe to deliver.
Yeah. So, for us, you have to be, for a patient to be a candidate for outpatient management, meaning management from home. You go home and you come into the office more frequently to, make sure things are stable. You need to live close by to the hospital. You've got to be reliable and make sure you make your appointments. You have to have the mildest form of preeclampsia. And what was the other thing I was going to say? Location. Again, location for me where I work, because I am high risk obstetrician, and we have patients that come from hundreds of miles away to come down to us. So we don't do as much outpatient management for the simple fact that these patients are so far away that they're not close. So it's better for us to keep them in the hospital. But, if you are a candidate for outpatient management, your doctor will determine that. And, that will mean more frequent visits into the office to be seen and have labs drawn in that, just in case your, disease process does start to take a turn.
Yes.
Yeah.
And we should say it's formally diagnosed when we see high blood pressure. So 2 high blood pressures diagnosed, 6 hours apart. That's one of the things we look at. And the blood pressure is going to be 140 over 90 or greater. That's kind of the level we look at. And we want 2 of those 6 hours apart, plus some other sign that the other organ systems are being affected. The protein in the urine, elevated liver enzymes, or maybe you're having symptoms like headaches and blurry vision.
Yeah.
It has to be most of the time.
Yeah. So preeclampsia is categorized as either preeclampsia without severe features and preeclampsia with severe features. Severe features, and we won't have to go into all of that here. That might be another discussion, but there's certain things we look in your labs and your symptoms and the baby status to determine whether or not you are preeclampsia without severe features and preeclampsia with severe features. Both of those diagnoses does not mean you have to be delivered immediately. We do try to get you to a certain gestational age if possible, with the understanding that things can change from day to day and you may change how severe your disease is. Then the next thing we would talk about is, as Dr. Hardy had mentioned, is HELP syndrome, which is your hemolysis means you're becoming anemic. Elevated liver enzymes or liver function tests means the liver is affected. And then low platelets. Platelets are the blood cells in your body that help like if you cut yourself, you get a little scab and a clot there. Well, you start getting low platelets. That means that you're more increased risk for bleeding. So that is the next severe form. And then the ultimate severe form is going to be eclampsia. And that is if your brain has been affected enough that you do have seizures. With HELLP syndrome and eclampsia, that does not, we try to get you at least 24 to 48 hours to get the baby's steroids on board, so to help mature their lungs, especially if they're preterm. But that usually means delivery within 24 to 48 hours, if not sooner. But like I said, preeclampsia with severe features and without, you can potentially get some more days, weeks to even several weeks, as long as you're stable. But with the other two, HELLP syndrome and eclampsia, that means you're going to have to deliver within 24 to 48 hours.
Yes.
Yeah. Okay, next question. So if I develop preeclampsia, how will my pregnancy management change? We talked about this a little bit. So we talked about
but basically it means that we are going to be watching you very closely. It may mean, like we said, if it's very stable and a very mild form of preeclampsia without, severe damage to your other organs, we can send you home and monitor you maybe twice a week in the office. But you also will be monitoring yourself at home. You'll be watching for blood pressure. You'll be watching for any symptom changes, headache developments, because if that happens, we want you to notify us immediately, because it could be a signal that the disease is progressing to a more severe form. If it's not as mild of a form, or things are not as stable, or you don't live close to the hospital, likely you will be staying in the hospital until delivery. When you have a mild form of preeclampsia that remains stable, we can usually get you to 37 weeks of gestation, and that's when it's recommended to go ahead and deliver the baby. If you have a more severe form of preeclampsia, our goal is to get you to 34 weeks of gestation, and that's when we generally say it's probably time to deliver the baby.
Yeah, so preeclampsia without severe features, our goal is to get you to 37 weeks. Preeclampsia with severe features, our goal is to get you to 34 weeks. And then, as I said before, HELLP syndrome and eclampsia means we try to get 24 to 48 hours for steroids for the baby's lungs, and then delivery. But the whole thing is, Dr. Hardy said, even though you might get diagnosed on day one with preeclampsia without severe features, it could change. So that's why, being compliant is so important, and doing what the docs tell you as far as coming in when you need to come in, or even if we determine that you need to be in the hospital for whatever reason. It's, as someone who was on hospital bed rest for 2 months, not for preeclampsia, but for other reasons, being in the hospital is incredibly difficult to do. You would think it would be a nice vacation where you could watch TV, and it's not necessarily that. So I totally sympathize and empathize with women who are on prolonged periods of hospital bed rest for preeclampsia, because I understand what it's like. But at the end of the day, it's for your benefit, your best interest and the best interest of your baby, in case your disease process does take a turn and you have immediate access to whatever it is that you need. Okay. Next question. If I develop preeclampsia, what are the risks to myself and my baby?
I was just thinking about that, actually, because we hadn't talked about it yet. So the risks, we'll talk about risk to mom. So we already talked about some of the more scary complications of having preeclampsia in pregnancy, with having seizures being one of the most severe things that can happen, because that means your brain's starting to be affected by all of the little vessel spasms and damage that's going on. You can have, if you can, this is one reason we watch you so closely, because we want to get to you and get things under control before any of this stuff happens. But, I always think of seizures being the main risk I think about with mom, but she can also have damage to other organs that might persist. It's not common, but it can. You can have everything from heart damage to liver damage, kidney damage. Most of the time it is reversible once the disease process starts to reverse. And we talk about the cure for preeclampsia is actually delivering the baby. That's why we try to get you as far as possible, but still weighing those risks and benefits.
Well, because we have two patients in one. So we have to consider the, weigh, what's best for mom versus what's best for baby may not always be the same. So as physicians, we have to think, which one is trumping the other one right now, which is not an easy thing to decide. because, we don't want to deliver a baby preterm, but we know mom is really sick, so we might have to deliver a baby preterm. So,
we're trying to prevent those other organs from getting permanent damage, like your liver and your kidney and your heart and your brain. I mean, that's the ultimate goal with preeclampsia management of mom, is keeping those things under control and keeping you healthy. And then for baby, some of the risk factors would be, those associated with premature delivery, needing long NICU stays, lung development, making sure that those little lungs are developed. And the risks while they're still in the uterus, are that any high blood pressure disorder, you have a risk that baby may not be growing as well, that the placental blood flow, which is what gives the baby all their nutrients and oxygen, could be compromised and cause them not to get all the nutrients that they need. You could also, with high blood pressure diseases, have separation of your placenta early. It's called a placental abruption, which becomes an emergency, and you can have other complications from that. That's a whole other.
So the placental abruption thing is probably one of the scariest parts for me as a high-risk doc when that occurs in a pregnancy, because there are cases that are diagnosed as the abruption's happening. They had no symptoms, and I'm not trying to scare women out there, but that's why we always,
that was the signaling.
I'm sorry?
That was the signaling symptom for me, was I started bleeding because my placenta was separating.
That's why it's so important. What I generally tell my patients is if they have spotting when they wipe, call the office. If you have bleeding like a period, you go to the nearest hospital. Even if it's not your hospital, you need to go to the nearest hospital because they could always transfer you. But, that should not be happening, especially into the second and third trimester, bleeding like a period. That should not happen. So, I mean, there's many reasons why it can happen, but, placental abruption is one of them. So there's been times where I diagnosed with a woman with preeclampsia after her placental abruption, as in the case of Dr. Hardy. So that's one, we always get asked certain baseline questions at every visit. And that's one of the reasons why we need to know if you're having bleeding or leakage of fluid and, is the baby moving okay and those things, because preeclampsia is one of the things that's in the back of our mind. What was the other thing? Risk of the baby. We talked about growth restriction. The main risk to the baby is the risk of being born premature. The earlier you deliver, you're thinking of extreme prematurity, which is like 26 weeks and under, the more risks there are to baby because of lack of lung and brain development. And then as you go on, you get a little bit further along, then lungs became one of the major issues that, can take the longest to develop. So it all depends on how early you have to deliver. And those are the main risks to baby. Okay. And this is where you could talk about your second pregnancy. So what can I do to prevent preeclampsia from occurring in my pregnancy?
So if you have preeclampsia in your first pregnancy or your second pregnancy, people are always wondering, is there anything else we can do to maybe help us not get this again? There's not really good screening for preeclampsia. A lot of times it just happens, out of the blue. There's nothing that really precipitates it. But if you had it before, especially if you had the onset of your preeclampsia less than 34 weeks, it's called early onset preeclampsia, we recommend doing something called baby aspirin. And it's 81 milligrams of aspirin that we have you start taking between 12 and 16 weeks of your pregnancy, preferably on the earlier side. And you pretty much take it throughout your whole pregnancy through 36 weeks. And it has very, pretty good evidence showing it can help decrease the risk of getting preeclampsia again, particularly that early onset preeclampsia. So that would be, one of the main things we can, as a doctor, that we can tell you to help prevent preeclampsia.
Yeah. So, and I had the table right in front of me. So basically we use this table and there's a lot on here, so I can't always keep it in my mind. So I always refer to it when I'm seeing patients, but we consider you high risk for having preeclampsia if you have a history of preeclampsia, as Dr. Hardy said, multiple gestation, twins, triplets, or more, pre-existing high blood pressure issues, diabetes, any kind of renal disease or kidney disease, and any kind of autoimmune disease, namely lupus. So that would put you in the high risk category. And if you have any of those risk factors, we are going to recommend that you take it. Then we drop down to the moderate risk category. That would be first baby. You're on the obese side or have a BMI greater than 30. Family history, like your mom or your sister had preeclampsia in her pregnancy. African-American race or low socioeconomic status is a risk factor as well. Age over 35. And then if you have other personal history risk factors, like you were born small or had other adverse outcomes in your other pregnancy, then those are to consider. If you have one or two or more of those risk factors, then we would consider having you take baby aspirin. So I am a huge advocate for baby aspirin. I think it works. There's a lot of evidence that it does work, but I always get asked, is it going to hurt my baby? So what do you say?
Typically there's risk for everything, driving a car to your doctor's appointment. But as a doctor, we think that the risks of preeclampsia really outweigh those risks of taking baby aspirin. It's a pretty benign medication with very low risk to your baby. And the most important thing is trying to prevent the reoccurrence of preeclampsia, because that can have much more dire effects than taking a tiny baby aspirin for your pregnancy.
Right. And you can get that over the counter, or I even write a prescription for it. I know a lot of my patients are on Medicaid, and it is covered by Medicaid. So I will order that for them. Or like I said, you can get it over the counter. There's really no special brand that's better than the other, as long as it's 81 milligrams. That's baby aspirin. That's a low dose baby aspirin is what it's called, not the full dose. So 81 milligrams over the counter, or again, we can write a prescription for it as well. But that's, other than, us being annoying and looking at all those risk factors of you and making you pee in a cup and get your weight and do your blood pressure and, poke and prod on you at every visit, those are the only real things, the best things we can do to prevent preeclampsia, or pick it up, as I should say. Pick it up at your routine prenatal visit. So I promise you, we're not being annoying. We are really looking out for other things. And while we're talking about the urine dip, so in the urine dip, actually, it tells us a lot. It can tell us if you're having protein in your urine. It can tell us if you're diabetic, if you're spilling glucose in your urine. That can tell me if you've been eating good or not, because you have a lot of glucose or sugar in your urine. I'm like, well, maybe you're not. So, and then the other thing we look for is blood in the urine. That could be an indication that you might be having a urinary tract infection. So the urine dip is actually what we call a urine dip, is when you pee in a cup and we dip this little, what is that thing called? Indicator strip. So it goes into the urine and it comes out all these pretty colors. And it's actually one of the greatest tools we have just for routine prenatal visits to kind of pick up on things that you may not even know are going on. So yes, we need you to leave that urine dip.
Wait with a glass of water until you give us your urine. So.
Yeah. Well, those are all the questions I have. This is very, very good discussion. Can you think of anything else we did not cover as a doc?
I think it was pretty thorough.
Wait, you didn't talk about your second pregnancy.
Oh,
yes.
That was a fun one too. So my second pregnancy, I decided to brave it again after the first go round.
How long after?
3. So we did wait. Particularly if you have early onset preeclampsia, I do not recommend you get pregnant right away. We want, I think an 18 month to 2 year interval is a pretty,
to allow your body to get back to
really get back to normal and heal. So I did have a second pregnancy. I took baby aspirin. I was followed by a maternal fetal medicine doctor from the get-go to make sure we were just watching for, any of those signs and symptoms coming up again. Watched for growth of the baby, made sure baby and placenta were always looking good. I did take that baby aspirin, and I did not get preeclampsia again. So I was very happy about that. I had a different issue where I broke my water early and had an abruption. But at 31.
So you broke your water. See, I didn't realize that. So you PPROM, or what's called preterm premature rupture of membrane. So you broke your water, and then how long after did you?
It was immediate. It was
it all happened at the same.
Massive eruption everywhere, and capillary uterus. And it was
nice.
That's how I do pregnancy.
Some people just do it that way. And listen, there's something to be said. I do have patients, have had patients over the years that are otherwise healthy, completely healthy, and no real medical conditions. But when it comes to pregnancy, they have this exact same thing that Dr. Hardy has. We don't know why. There could be a genetic component. It could just be something with in the woman's body, maybe something with antibody, who knows? It's hard to tease out because there's so many things that it could be. But, I guess the moral of that story is, having good early onset of prenatal care is so important. Going to your prenatal visits, listening to your body. If you don't have, if you have questions, ask them. We're not trying to scare anybody. I'm not, don't want you to come away from this thinking, oh my God, I got to check my blood pressure every day. And, because then you're going to stress yourself out and then you're going to have a high blood pressure. But being aware and being informed as a patient is great. And, being able to ask your doctor questions is also great. I know sometimes it's not easy to do because a lot of times we're rushed, but, sometimes I'm going to say this, if you feel like your doctor is rushing you too much, tell them to take a minute. I have a question. Can you please, I need more time. And sometimes it takes that to kind of snap us out of it, and we'll do that. And, we're not perfect as physicians, and sometimes we do get too busy. But, any doc that's a good doc is going to say, okay, you're right. Let's talk. What is it that's worrying you? Would you agree?
Yes, absolutely.
Yeah.
And one other thing I was going to bring up, I forgot to let you know how common hypertensive disorders are, but basically 10% of all pregnancies are going to have some kind of high blood pressure disorder, whether it's just chronic high blood pressure or gestational hypertension, which is just high blood pressure, not preeclampsia or preeclampsia. So 90% of the time, you're going to, you're likely going to be just fine. And then 10% of the time, 10% of patients are going to have some kind of high blood pressure issue in pregnancy.
Yeah, so it is one of the most common medical conditions in pregnancy. That's why we watch for it so closely. But it doesn't mean you're going to have it. But as long as you're informed, then you'll know what to look for and know when to call your doc. Well, it's been a pleasure. We'll have to do another one. I'm super excited. Bella ObGyn is amazing practice in the Houston area. So you can look up Dr. Hardy. Tell us what your social media is, by the way. How can they find you?
So you can find us at our website, which if you just Google bellaobgyn.com, we are there. We have an Instagram page at bella.obgyn where we try to post, useful information, updates about our practice, medical, information that might be helpful to you. And we also have a Facebook page at Bella Obstetrics and Gynecology.
Perfect. And guys, I know how to find me, babiesafter35.com. Again, this is Preeclampsia Awareness Month. I do have stuff on my social media and on the website if you want to get additional information. You can also go to preeclampsia.org to get more information. You can go to preeclampsiaregistry.org to get more information. Those are the two. You can also go to acog.org to get some good information. Those are probably the three best resources I can think online to get some stuff this month on preeclampsia. If you guys have any other questions after this, you can always private message me on social media or go to Bella ObGyn and private message as well. And we will do our best to answer any questions.
Yeah.
All right. Well, enjoy the rest of your weekend. I thank you so much for taking your time. I know this is a little mini staycay for you. So tell your family I said hello. And thanks again. And we'll hook after this is all over. We need to say hi.
Isolate quarantine. It'd be great.
It'll be over one day. All right. Thank you.
Bye.
Bye.